Alright, is everybody good? Alright guys, so I'm Firefighter Chavez. I've met I think all of you guys at least once now. I know there's a lot of people that I've only met a handful of times. But I'll be doing a presentation today on the art of the radio report. What's that?
Aren't you a medic?
Yeah, so Medic Chavez, thank you guys. Yeah, as of yesterday morning, I guess I'm now a paramedic.
Nice.
So, real excited about that. However, I was an EMT for 6 years prior to that. I have a lot of experience with transport, both here as well as AAS and high call volume systems. So it's fair to say I've done a fair amount of radio reports and learned a lot of things along the way. We do have a lot of new providers, and I think you guys would probably agree that radio reports are something that kind of gets glossed over in class. It's like real quick, and then a lot of times, at least I remember from mine, we would do one during a scenario and they'd be like, oh, that was all right, but cool, don't worry about it. And then that was about all the training you got. Is that fair to say? Yeah? Okay. So we're going to be going over that today, and this goes hand in hand with patient advocacy and doing the right thing for your patients, and that tends to be a theme that we're kind of going through today. So radio reports, important part is clear, concise, and with a purpose, right? So what do we call reports? What it is not. So it's not an arbitrary task or a checkbox in patient care, right? We're doing it, again, for a purpose. There's a reason that we're calling the radio report. This isn't something to just be done before the hospital and, whatever information gets relayed. So an effective radio report can definitely affect patient outcomes. It's also not a detailed turnover of patient care. So you're not going to want to be saying everything that you need to say about the patient over the radio. So you're not giving a report to a nurse or the receiving facility. You're not giving them, full history, all the impertinent details, all that kind of stuff. So this is very concise. So now we get into the objective of the radio report. So again, the goal is to advocate for the patient's needs. So we're alerting the ER of what they need to expect with us bringing the patient in. We're also letting them know what we need, and it's allowing them to determine what they need additionally to prepare for this patient, right? So if we're calling, say, like a STEMI alert, they know that they need to have a cardiac team there. They need to be ready to move to the to the cath lab. We're calling a stroke alert. It lets them know that they need to have neurology on site. They need to be getting access, or if we have access, we'll get into that, but what the next steps are, right? Because if we bring a stroke in without conveying that, now we're having to wait for them to activate the stroke alert. We're having to wait for neurology to come down. We're having to wait for more doctors to come down, and it's ultimately just extending that patient care window, right? And if we're approaching, the 4.5 hours for TPA, like we talked about earlier, this could just cause further delay in treatment. So critical information that needs to be included. This is a list here. Now, not every radio report will need this. We'll go into detail, but not every radio report will need every aspect. Some things will be added or deleted, but for the most part, this is what should be included for an effective radio report. So the first one being agency, unit. So I added some things. I got feedback from a lot of the experienced providers. I talked to a lot of people in the department. I also talked to a lot of the receiving facilities that we generally go to as far as feedback. So I have some new things that I threw in here that I think are super helpful. Again, your radio report's kind of going to be your own. You're going to get your own style and what's effective. But these are all things to consider and could be helpful to you, especially maybe you newer guys that are kind of trying to get a feel for it. So the first one is the BLS ILS status if necessary. That one was never taught to me, but we kind of went over that today. So if we're bringing, say, a stroke alert, right? What does the hospital expect for us to have in place from our ALS providers? IV, right? Access, sufficient access, and not just an IV at that, right? What are they expecting? Something high up, big gauge for contrast, right? Now, if we show up without it, now it doesn't really matter, if this facility's judging us saying, oh, they weren't prepared, whatever the case is, that's not the issue. The issue is that they need to be prepared that if a BLS unit is bringing that they know there's not going to be access. Right, so if you guys are BLS bringing in, say, a stroke alert, and you make that clear over the radio report, now they know, okay, we're going to need supplies to get that established before we roll the CT. Same thing with ILS, right? Another one being like stroke alerts. I'm sorry, I said stroke alerts, like a STEMI alert, right? We can transmit it. We can say, hey, we're coming in with a stroke alert. The monitor says this, but they know that you're BLS, so they know that they need to have a doctor, somebody there to be able to interpret what's going on, kind of reassess and go from there, because they know there's not a paramedic saying, I'm bringing this STEMI, right? So that's kind of a big one that I added. I got a lot of feedback on that. I think it's definitely very beneficial to know, again, what's coming in and what they need to do to prepare to receive this patient, whether it's an ILS truck bringing them, an ALS truck, a BLS truck. Changes in treatment are going to dictate what they need. priority of transport. Now, traditionally, this is code 1, code 3, right? Sorry, let me go through here. We'll kind of hit them in order. I'm kind of jumping ahead here. So unit identification, basic identification. It can have pleasantries, but this should be kept short, right? You shouldn't be on the radio talking to people. Hey, you awesome people, this is blah, 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 and delaying further patient care, right? That's just excessive. Now, where this could be good is it could help you build that rapport with our facilities that we normally go to. Russ, Loveless West Side. You know, for me, I always include, hey, good morning, Russ, good evening, Russ, this is Dennis, and then I know it's me. I know a lot of people there. The more you guys transport, the more you guys work in the system, you're going to get to know people. And if you establish a good rapport and a good reputation for yourself, it's going to help you out in the long run, right? They're going to say, hey, this guy's squared away. He knows what he's doing. I know who it is on the radio, and this is what he's asking for, so we better get it, right? Versus somebody random coming in, you know, somebody newer. They may or may not be as willing to accept the feedback that you're giving over the radio, which isn't a big deal. Again, it's just something that we need to establish. So it can be good. Again, it should be kept to a minimum, though, and it shouldn't be impairing or making your radio report longer by any means, right? Depending on the nature of call, it's good to identify the unit's level of care. So that's what we talked about with the ILS BLS. Any questions on that? No. So next up is emergent versus non-emergent. This is another thing that I got a lot of feedback on, and this is something that could be more useful. So again, code 1 or code 3 has traditionally been the standard, right? This is Rescue 1 coming to you guys, code 1 or code 3. What exactly does that tell the hospital? What does that convey? Urgency, potentially. Now, us being Rio Rancho, how often do we do code 3 recurrence, especially compared to another agency? Not very, right? So working in, like I said, I work with AAS and a lot of other agencies. If we're running a stroke alert, a STEMI alert, something like that, that's automatic code 3. So we're coming code 3. Now, for us in Rio Rancho, proximity to the hospital, right? If we're not approaching that 4-minute window and it's in our protocol and the patient's stable, we may be bringing a stroke alert into Rust code 1. Does that necessarily mean that that is not an emergent transport? They still need to be ready with the neurology team, right? They still need to be ready to receive the stroke. They need to be ready to go to CT and all these different aspects of patient care. But just because we're not driving lights and sirens doesn't mean that there's any less urgency with that. So one of the things that I got a lot of feedback on was emergent versus non-emergent, right? If we tell them we're coming emergent, we know it's something that they're going to need resources for, it's something to prepare for. If it's non-emergent, that's your twisted ankle, your stomach ache, whatever you're expecting to probably go to triage that you're not going to need additional resources for. Now again, this isn't something that's like set in stone. I'm not telling you 100% have to do this, but based on feedback from both our end and the receiving end, this is something that could be a lot more useful. Again, this facility, and this isn't a dig on the facilities, this is just something I got from feedback in their own words, was that the person answering that radio may not even know what code 1 or code 3 is. Not everybody at these hospitals know that code 3 means lights and sirens. So they hear that and that automatically just gets thrown out in the beginning of the radio report. Does that make sense? We got rid of 10 codes a long time ago. What do we always use now? Plain text, right? We just say what it is. So if you hear an emergent transport coming in, that kind of keys you in on, hey, we should get ready for this versus non-emergent, right? So again, just a suggestion. I included this in my radio reports now. I like it. I think it's very effective. So. Next up is patient demos. So this is super basic, just age and gender, right? I don't think that needs much explanation. Don't give out identifiers, with the exception being the VA, right? So we're not giving patient's name, anything further. We're coming with a 65-year-old female, 52-year-old male, whatever the case is. Again, the VA is its own beast, so I'm not going to get into that. But we're all aware, right? They ask for, I think it's the last 4 of the social, date of birth, and what is it, age and gender?
Last name.
Yeah, last name, last initial. So they're definitely an interesting case. But any questions on demos? I mean, that one's probably the most self-explanatory part of the radio report, correct? Sweet. So moving along, right? We've called the facility. We've told them this is an emergent or non-emergent. This is the BLS truck. We've given patient identifiers. So remember with your radio report, you want to push the more urgent things to the beginning, right? Because you don't want to get to the end of your radio report with them thinking, oh, this is a solid patient, vital stable, we're good to go, and then all of a sudden at the end of the report, you're like, by the way, this is stroke alert, C5, right? You see how that could be an issue. So you definitely want to bump up the more urgent things to the front. Now, we talked about, our stroke centers, we talked about our STEMI centers, all that stuff throughout the day in some of the other presentations. So this would be the time to add it in early in the report. So again, these are the alerts, the trauma, sepsis, stroke, STEMI, and then that's also going to kind of guide where you're going, right? But again, we may be taking a trauma alert to SRMC because the situation dictates. That's not to say that every trauma alert is going to UNM, but whatever facility you're going to, you definitely want to alert them that you're en route with it. Like in Scott's presentation, he was saying as soon as you call an alert, it gets things rolling, right? If I call a trauma alert to SRMC, they're going to start getting their trauma teams ready. They're going to start getting everything ready so that by the time we hit the door, we're already that much further ahead in patient care. So that's why he's saying getting these early is very important. Again, BLS identification with these is important. Again, just some of the interventions that they may be expecting, or they know what they're going to receive and what they're going to have to do. So some examples just with what we've compiled so far. So first one, SRMC, this is Rescue 5. We are BLS bringing an emergent transport. We have a 76-year-old female. This is going to be a stroke alert. So we're building up, so that'd be the first part of the radio report. Does that seem like it flows pretty good to everybody? You don't have a lot of information in there that doesn't need to be. It kind of conveys it, and then just based off of that right there, do you think that they're going to be expecting to have to provide a lot of resources for this patient as they're coming in?
Yeah.
Yes? No? Yeah, right, because it's a stroke alert, so you're going to need neuro. It's emergent, so they're thinking, okay, this is definitely something that's coming in hot, and they're going to need some resources for it. The next one is, good evening, Russ. This is John on Rescue 3 with a non-emergent transport. We have a 68-year-old male. This is going to be a sepsis alert. Okay, so what is this one telling us? Again, it's a sepsis alert, right? And we don't have the rest of it, but this might be a case where he meets serious criteria, but he's alert and oriented. He's sitting on the gurney talking to you with no other issues, right? We might have gotten a line. Now we're just transporting him because, he meets sepsis criteria, so he's a sepsis alert. However, we're still non-emergent, right? You see where the code 1 versus code 3 can be a little convoluted. So I feel like that's definitely a good indicator. That was one of the things I liked when I was getting feedback. Does that make sense to everybody? So next, you want to present the patient's primary concern or chief complaint. Traditionally, again, this has always been expressed as the chief complaint, but I think where this definitely differs is the chief complaint is not always the main concern, right? We might get an old lady who calls us because she hit her foot and now her toe hurts, but while we're there, we end up seeing that her blood sugar is 400, right? Or maybe somebody fell and called because their arm hurts, but now all of a sudden we find that they're in sepsis or they're having an MI, right? So the chief complaint isn't not significant. That's something that you want to give during turnover when you're face-to-face and you're presenting all the information to whatever the receiving facility is going to be. However, over the radio, right, if you have something more critical, say like a STEMI alert that you found on this patient that's complaining of foot pain, is the foot pain really relevant at this point in time? What do you guys think?
No.
No? No, right? Because it's not guiding our treatment. It's not going to guide what the hospital has to do when we get there. It's not going to guide any of the further treatment. So you're going to want to present with what you're transporting for and what you're worried about. So that would be, say, the STEMI alert, the sepsis alert, whatever is the most critical, whatever your reason for transport is. Okay. So next up is A&O status, vitals, interventions. Nothing changes there, right? We're going to let them know if they're responsive, what they're responsive to, whatever their baseline is. That's always a big one to include. If you tell them they're A&O times 3, they'll probably ask you, but if they don't, they're wondering, is this changed, right? Is it somebody with dementia who's always oriented times 2? Or is this an acute thing being caused by whatever you're bringing them in for? Again, vital signs, interventions, what you've done for them. I want to reiterate that you can bump things up in your radio report based on importance, right? So if their vital signs are stable, you want to go through your radio report, you get your vital signs, and then you continue on. Right now, if you got there and on room air they were satting 65%, right? It might sound something like, good morning, this is Rescue 5 coming to you guys emergently or non-emergently with a 65-year-old female. Chief complaints hypoxia. On scene, room air sat was 65%. You see how that becomes now more pertinent? Like, you don't want to bump stuff up if it's not pertinent because you're going to hit it in your vital signs. But if it's pertinent to patient care and you're kind of trying to paint that picture of, hey, this person's hypoxic, they're really working to breathe, that's when you want to bump stuff up in your radio report. Otherwise, it falls, where it does in the radio report, and it's good to have that style of that flow. So you just hit everyone the same, so it's nice and concise and you can flow through it. Here's where we have special considerations, patient advocacy. So again, this is where you might reiterate something that maybe wasn't super clear to begin with, or that's super clear with the chief complaint. This could also be, where you call in with, hey, this patient's A&O times 4, complaining of headache for the past 5 days. Here's the vitals, cool, and they're like, all right, you can go to triage. But you're like, wait a minute, this patient is bedbound from Genesis, right? They can't sit in a wheelchair. So this would be where you now want to advocate for your patient. You want to take those special considerations in and say, hey, that's not going to work. This patient's bedbound. Maybe let them know that, to let them know again what you need from them. But it also is worth mentioning that you don't want to be arguing over the radio. So if they tell you go to triage and you say like, hey, this patient's bedbound, they're probably going to need a bed, and they're like, oh, well, we don't have any beds, they need to go to triage, blah, blah, blah. This isn't the time to go back and forth with them over the radio. There's other units that need that med channel, and again, you want to keep it concise. So at that point, this would be a time to say, all right, we'll see you when we get there. And then the proper thing to do would be once you get there, right, once you get to registration, you talk to that intake nurse to say, hey, can we talk, can I talk to maybe the charge or the intake nurse to see, to talk about the patient's condition or advocate for the patient at that point. Now, ultimately, it is the facility's choice. If they want to go to triage and you try to advocate otherwise and they tell you at the end of the day go to triage, then that's where they're going. In that case, you just want to document it. You want to make sure in there that you advocated for the patient. This is what I asked for, this is why they said no, and this is who I turned over to. One of the things that I did want to mention also, this came from Eric's recommendation, was that Russ specifically, some of the other hospitals as well, but Russ specifically, they have providers up in triage. I don't know if everybody's aware of that, because they do send a fair amount of people up to triage. But in that secondary triage area, they have generally PAs, NPs, and even doctors that are going to start assessing and getting the ball rolling in that treatment. So just because you're going to the waiting room doesn't mean they're going to sit there for 6 hours and not be triaged or care is going to be started on them. So that's one thing to take into consideration too, is we don't know every hospital's flow and the way that they handle it. So they may be telling you to go somewhere that's completely appropriate, and just our perception of it isn't that, right? So we want to advocate for our patient, but again, it is up to them. They're going to treat that patient how they feel accordingly. So, questions with that? Last thing is questions and ETA. So at the end of the radio report, you're going to say, we'll get you to the door in 5, any questions? Now, I'm not a huge fan, personally, of asking questions and orders. We're all competent providers, correct? Asking for orders over the radio over a patient, to me, just comes off as, did I do anything wrong? So I like to ask for questions. You guys have any questions about it? Now, if they have anything for you, they'll give that feedback. But if you're asking questions and orders, we should be competent in our practice. We should know what we need to do, and that's just kind of giving that signal that, we don't need to be asking for that. Now, if you're actually asking for something, so you have a critical patient, you're like, hey, doc, what do you want me to do? It's different, right? Because we can always call receiving facility, because we have MSEP, right, which is our consortium. We also have MSEP, so you can get orders from the receiving facility, so that's different. But if you want to be a competent provider and know what you're talking about and kind of give that image off, again, establishing that rapport and that reputation with not only hospitals but our peers, I like to just ask for questions, and obviously if there's an issue or something to address, they will ask it at that time. ETA, again, just roughly how long it's going to take to get there, so they know how much time they have to prepare. Earlier is always better, right? More time to prepare is better if you know it's going to be something critical. If we do it all the time at 2410 Rio Cabazon, because it's right across the street from Russ, right? We want to try to give them as much of a notice as we can. So a lot of times while the rest of the crew is loading up the patient, you might be able to sneak away and call your radio report real quick in the parking lot before you take off. Again, it's just a courtesy thing. The longer they have to prepare for somebody, the better the outcome is going to be. So your turn now. I have a couple scenarios up here. There's a lot of information in here. I have a lot of distractors. I want you guys to kind of read both of these real quick. I'm going to call on a couple people to give me a radio report on each one. Now, if you have your own style and the way you do it, that's fine. I would love to hear that as well. If you want to take some suggestions from what I presented and the way I told you, that's great also. But I'm going to call on a couple people for each one just to kind of hear the differences, and we can kind of critique them a little bit, all right? I'll give you guys a couple minutes here. Also, I know it's been a long day, so I'm trying to keep mine nice and short and concise for you guys so we can get out of here. All right, you guys got a good minute to look at those? Cool. All right, so we'll start with this one, the 67-year-old female, all right? Remind me of your name here, my friend? Segura. Segura, I'm gonna pick on you, all right? I want you to give me a radio report there. Now, obviously, if you're BLS, don't worry about EKG or like the IV interventions, okay?
So just leave out the IV. So I wouldn't. Just the blood pressure would be the 87.
Yeah, you can just give me that first one.
Okay.
So we'll run it as you've already cleared the med channel. You're now talking to whatever facility you want to go to.
Okay. Less medical. This is Rio Rescue 10.
Okay, go ahead, Tim.
This is Rio Rescue 10. We are currently en route to facility. Code 1 with a 67-year-old female with a chief complaint of syncope. Patient did have a syncope episode on scene. Patient also has a history of hypertension, diabetes, and CVA. Patient's vitals are as follow. We have a pulse of 64, weak and regular. We have a blood pressure of 87 over 56, respiratory rate of 15, and SpO2 of 95 on 2 liters per minute via nasal cannula, and a BGL of 101. If we have no further questions or concerns, would be to facility in about 8 minutes.
Sweet. No questions? Cool. How do you feel that went? Okay. So we'll hold that for a second. Now let's do Mike Ernest. Do you mind? Do you want to give me a radio report for that same patient?
Yeah, last interaction facility coming to you, code 1, 67-year-old female, unwitnessed syncopal episode. Patient is now alert oriented. Vital signs include a weak radial pulse of 64, BP of 87 over 56, a respiratory rate of 15, satting 95% on 2 liters per minute. IV placed, bolusing 250 or 500, whatever it is. I mentioned a new blood pressure if it's pertinent, and 96 over 60 after fluid bolus, and EKG is 12 lead or 4 lead is normal sinus. ETA about 10 minutes. Unless you have questions, I'll see you then.
Sweet. No, sounds good. Cool. What do you guys notice about the difference in those reports? And I'm not blasting you. I purposefully picked you, and then I purposefully picked Mike Ernest back there because there's a lot of takeaways from both, and I think it's good to kind of hear them back to back. Car.
Ernest left all the distraction stuff out.
Yeah, exactly. So this is a big one that I hear, and I've heard a lot of people mention from like our more experienced providers, right? This past medical history right here, I put that in as a distractor, right? And during the radio report, we don't necessarily need that, especially for this patient. Potentially the hypertension, right? What was that?
I would have said the blood thinner though.
Yeah, metoprolol?
If she just let the
Oh, I'm sorry, the warfarin. Yeah, the warfarin,
I would have
correct.
mentioned that.
The main thing with this one is that, at least again, this is me, right? This is me mentioning for radio reports. There was a recent change in medication yesterday, right? And now she's having a syncopal episode. So that for me is the big takeaway to convey, because that's now showing causation and what happened and the fact that they could be related, right? The rest of the stuff could probably be mentioned in a face-to-face, especially like the allergy. She makes a good point with the blood thinners because that is important. But like the change in medication, now she's having syncope, that's kind of the important part. Mike Ernest, when he mentioned, I liked when he mentioned down here, he said line in place with the 250 bolus. You don't need to include all the specifics of your interventions in the radio report because again, they're being done, right? You say, I have a line in place, we've given a bolus, this is the improvement. You could give the amount of the bolus like you did the 250, but is it important that you have a 20 gauge IV in the left AC for this patient? Not necessarily, correct? Now, if it's a stroke patient, potentially that changes things, but he was very concise to the point. Yours was good as well. I think you hit pretty much everything you could, and again, as a BLS provider, that's kind of what we're going for there. Just be careful with distracting information.
Oh,
Does anybody else have any comments, anything that you like to do, anything else you can add to that? No?
I was just as like a little added thing in case they don't hear the numbers or like they kind of mishear the numbers on the blood pressure. I would even say like patient is currently hypotensive with a blood pressure of 87 over 56.
Yeah.
Just in case they miss the numbers. Sometimes they'll like you tell them that their vitals at pass on, and they're like, wait, what? Their pressures were what? You're like, oh yeah, I said on the radio report. It's like, well, I didn't hear that. But if you say like, oh, they're presenting hypotensive with a blood pressure of 87 over 56, it's a little extra fluff, but I think it kind of helps highlight the main issue that's going on.
Yeah, exactly. Like Carl said, you want to enunciate and kind of help paint that picture of what exactly you're presenting, right? So this patient, the hypotension is the main concern at this time, right? With this patient, I'm thinking probably metoprolol, the increase of the blood pressure, the medication caused the blood pressure to tank. That's why they're probably not having syncope. At least that'd be like my working diagnosis. So like Carl said, I would probably attack this as once I hit vitals, I'd say 64 week and regular at the radial. BP on scene was 87 over 56 with the bolus. It's now gone up to 96 over 60, and then keep going, right? Or hypertensive on scene, like you said, hypotensive on scene at 87 over 56. You just want to enunciate that, and then you fix the issue, right? Your pressure's still soft, but it's not considered hypotensive, right? Because it's over the 90 threshold now, which is what we look for with the fluid bolus. So you want to enunciate what you're doing and how your medications have affected that. Anybody else have anything for this first one? Okay, we're going to move to the second one. We'll do the same thing. I'll pick somebody a little bit newer, and then we'll move to maybe somebody who's a little more experienced and kind of compare and contrast, okay? Costa, you want to give me a radio report for that one?
Yeah. Could have said no.
RCR's rear entry rescue 10.
Go ahead, Costa.
This rear entry rescue 10 currently en route to your facility code 3 with an 87-year-old female. This is going to be a sepsis alert. Got a blood pressure of 88 over 62, temp of 102. Is that SRR the rate?
Strong and regular at the radial.
Okay, strong. Heart rate of 112. Patient is ANO times 4. We have her on nasal cannula at 4 liters a minute, currently satting at 92. Room air sat was 88. We're about 5 minutes out. Do you have any questions for us?
Oh, no questions. That was pretty good. I actually like that a lot. But before we jump into that one, let's just get somebody else who else wants to give. John, you want to do one? I know you're used to driving that ladder now, but if you can dig in there and find a radio report.
Establishing garden legs.
All right, fire control engine 3.
You are in fire control, sir. You're going to Med 7.
No.
Got about
Hear me out. Engine 3 en route to SRMC to pick up personnel. That's my usual radio report.
That's perfect.
You should just call out of service and go back to the station. They'll bring you back.
No, I'm nice.
All right, you know what? Fair. I'll give you that.
I can do it.
All right,
I was just messing around. Okay, fire control rescue 3.
Go to rescue.
Shit, okay, that was a mess
Okay, never mind.
Rescue 3 en route. Code 1 with an 87-year-old female. Chief complaint of left knee pain. She has a wound in the area with purulent discharge. She's awake, answers appropriately. Vitals as follows. Rattle off all the vitals, you can read them there. She's on nasal cannula, IV established with 250 on board. Questions?
To the point.
Hasn't
No,
been that
that's-
long
I
since
mean,
I ride no bike, John.
you hit everything, right? David,
See,
you wanna
that's
take a
why I
shot
don't
at
need to
this
get
one?
back on a rescue, because I still
Sure.
remember.
I know
Oh, you're
your
good.
reports are great.
Well, I appreciate that. Where are we going?
I want you to smile.
Wherever
while
you
you're
want.
saying
This is your chance to take wherever you want.
They can hear that smile.
Oh, okay. Sandoval Regional, Rear Entry Rescue 5.
Go to Scott.
Good afternoon, Paramedic Gonzalez currently en route with an 87-year-old female. Chief complaint today is going to be left knee pain. Patient's otherwise been, I'm sorry, there was no injuries, right?
Not to the knee, no.
Oh, okay. Patient's chief complaint is a left knee injury. Currently, patient also has some vital signs, possible signs of a sepsis alert. Does have a possible source of infection. Last of vitals as follows, showing a heart rate 112, strong and regular, mildly hypotensive at 88/62, respirators of 30, setting 92 on 4 liters on nasal cannula, showing sinus tachycardia monitor and temp of 105. We do have IV access with the fluid bolus. If you don't have any questions, we should see you in about 5 minutes.
No questions.
Not
How do
many
you guys feel
of
that
those.
one was?
105, they're
Yeah,
fine.
102.5
so
miles.
far.
Oh, my bad.
No, you're good. No, I like it though, because again, we talk about like the pleasantries, right? I'm sure everybody in this area knows when they hear paramedic Gonzalez, they stop to listen to what he's going to say. He identified that it was a sepsis alert. He let us know, he listed some of the serious criteria, right? He let them know that there was a wound that was possibly infected, and then as he hit the vitals, he explained that she was hypotensive tachycardic, right? So I feel like that very much conveyed this patient and what was going on with her. And it had a really good flow. I'm sure a lot of your radio reports sound similar, right? Just changing, obviously, what needs to be changed patient to patient.
I use a template.
Fair. So yeah, no, I mean it's a flow. Like I don't use template, but all of mine kind of sound the same, just because that's the way it works, right?
Rescue 10, I'm gonna change that for you.
Right.
Here we go, all about templates.
So any critiques, anything anybody has question-wise on that one? So again, for this one, right, the big thing is the sepsis. The knee thing is kind of, I don't know if it was a little, I mean, obviously it's supposed to be distracting, that's why I typed it out this way, but the wound was actually on the arm that was infected from a fall that wasn't related to the knee pain today. So for me personally, it'd be, sepsis alert, he's got a possibly infected wound, she's tachycardic, tachypnic, and hypotensive, and I go into vitals, right, listing the same thing. All the same information, that's just the way that I would attack it. But the main thing is, we're cutting out the unnecessary information. You don't want to be in here talking about how the knee pain is 4 out of 10 and how, it's exacerbated with exertion, that kind of stuff, right? Because at this time, that's not the issue that we're presenting to the hospital or the reason for the transport. Does that make sense?
Do you read off from this? Oh, okay.
Sweet. And then again, just reiterating, patient advocacy is a big one. Just because we present something in one way, the hospital may take it as, hey, this patient can go to triage, or maybe this patient needs a room, and that's when you want to take the opportunity to advocate for your patient and where you need them to go, where you think that they should go, and kind of reiterate that to the hospital. That's about all I got here. Any questions regarding that? So just real quick, now after we went into detail about all this stuff, I'll go back to that first slide, which was
all over again.
I was just gonna say the same thing.
What was that?
About like needing a bed necessarily, because they can give you gurneys to go to triage.
Yeah, that's
You don't necessarily need a room if the patient needs a bed and they're triage appropriate.
Yeah, that's a good point, right? And going back to the example of this patient's coming from 40 to 10, they're bedbound, right? And their chief complaint may be something that doesn't warrant them needing a room, but because they are bedbound. Russ will do this a lot. I haven't seen too much at the other facilities, but I mean, you may run into it, and it's fair that they need a bed, but they can go up to the lobby or up to triage in a bed just because they're bedbound doesn't jump them to the front of the acuitive line. So that's a good point, thank you. So here it is, again, just listed out. This is all the stuff that I went over and what to include and consider in your rating report, just condensed. So, any last questions? No? Cool. That's all I got for you guys today.
Congrats on getting your medic license.
Thank you,
Yeah.
appreciate it.
Congrats.